Madam Dr. Bharti Rajshekar and Dr. Sneha and everybody here, I think we should be starting off.
Yes, ma'am. Yes, ma'am. We are live now.
Yes. Yes,
Uh,
yes. Dr. Sunita ma'am is also joining. You can start by the time.
Yes, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, episode 21 of Amogs Emergency Obstetrics Committee with Ksoga. It's my pleasure to invite the convener of today's webinar, Dr. Sonia ma'am. Ma'am is the secretary of Ksoga, Advisor Safe Motherhood Committee, Ksoga 23 to 25, Advisor Breast Imaging Committee, Ksoga 23 to 25. I welcome you, ma'am.
Thank you. I recorrect you. It is KCOG. It is Karnataka College of Obs and Gyn.
Okay, ma'am.
Thank you.
It's my honor to invite Dr. Anita ma'am. Ma'am is the Assistant Professor, MR Medical College, Kalaburagi, Treasurer of Gulbarga Obstetrics and Gynecology Society from 2022 to 23, Secretary Gulbarga Obs Gyn Society, Kalaburgi 23 to 24. I welcome you, ma'am, and I hand over the session for further proceedings.
Thank you, Sahiti. On behalf of everyone, I welcome for today's webinar, Amogs, and in association with Ksoga. So this program is going on under the guidance of Dr. Sneha Bhuiyan ma'am. So beginning with, I request Sahiti to put on the welcome light lamp lighting video.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
Thank you. Moving on, I welcome you all for this webinar on Ksoga, Amogs and Ksoga. I did like to welcome the Ksoga. Yes, ma'am.
Introduction, and we go ahead straightway for the formalities. Okay.
Okay,
I'd like to state my introduction. Very good evening to all of you. And first and foremost, we welcome the respected chief guest for today's program, Dr. M.J. Hiremat sir and Madam Sunita Tandurwadkar, FOGSI President-elect. And of course, I also welcome the guest of honor, Dr. Bharti Rajshekar, the President of Ksoga, and Dr. Ajay Mane, the Vice President of FOGSI. I welcome the entire team of Amogs office bearers and Ksoga office bearers, including Sir M.J. Hiremat, Dr. Nagraj, Dr. Vidyatabi, the immediate past president, Dr. Bharti Rajshekar. We have already welcomed Dr. Rajesh Palladi, the secretary, Dr. Suman Gaddi, the treasurer, and of course, Dr. Durgadas, the president-elect. I also welcome the Amogs team, Dr. Kiran Kurtakoti, President, Dr. Bipin Pandit, Secretary, Dr. Rajendra Singh Pardesi, the immediate past President of Amogs, and of course, Treasurer Amogs, Dr. Madhuri Mehta. I welcome the speaker for today's program, Dr. Parag Biniwale, who is going to speak on obstruction of placenty. And of course, I'm going to moderate the panel discussion on hyperglycemia and pregnancy. I welcome all the respected chairperson and the panelists for today's program. So without much ado, I think we go ahead with the formalities of having the blessing. We have already received the blessings of God, and we now go ahead for the blessings of our respected chief guests. So over to you, Dr. Sonia, once again. Today, I think it will be a little difficult for me to read out the introduction also. So I hand over the mic to you once again, Dr. Sonia. Please invite our chief guests and continue the formalities. I am here, but past. Thank you so much once again. And over to you, Dr. Sonia.
On this note, I bring greetings from our fraternity to every participant who's already connected and those who will be getting connected. And we have our esteemed guests today, Dr. Hiremat and Dr. Sunita. Dr. Hiremat would be joining us in a while. We would like to hear from Dr. Sunita Tanulkar. Madam, I think I saw Madam has joined.
Hi, I'm very
Yeah.
much here.
Yes, Madam. Welcome you on this
Please
platform.
don't read my CV. We are all friends. Everyone knows
We would like to hear from
everything. I better have you all seen than having my CV over there. So first of all, thank you so much. Amogs, very vibrant committee, I will say, when Sneha has become a chairperson, and Ksoga, another vibrant organization. So two major states coming together is a golden opportunity. And when you have Dr. Parag Biniwale as a speaker, I think, Sneha, you will have at least 50 people more joining because everyone either want to hear or see Parag. And yourself conducting the panel will be always a great, Sneha. I have heard you always with the amount of expertise or amount of passion, hard work you put in your every work. It's admirable, Sneha. I wish you all the best, and let me openly say that it is my loss that you are not working with me, and it is loss of someone else also, but probably the gain of maybe, I don't know who, but the gain of someone. So, Sneha, I know you are in Delhi, you are multitasking. I think you don't need to do that much, but take care of your health. I see Dr. Pardeshi sir and Dr. Vidya Thobi, who has made these organizations so vibrant. And fortunately, they got the best leaders ahead, Dr. Kiran Kurtakoti and Dr. Kasturi, Dr. Bharti. So automatically the Ksoga and Amogs are absolutely on their best terms. Ajay, I know one day will come where you will be the president of Amogs as well. And I'm sure it will not be too far away. We have Parag Biniwale, who has a capacity to become a Foxy president. So I think this entire your team is all vibrant people coming together. And Rajeshri Paladi, I love you. You
Thank
are
you,
one
ma'am.
of the most sincere Ksoga member I know. Whether you are in Rajasthan, Gujarat, underwater, overwater, you will join for the webinars. I have experienced it. So all the best to all of
Thank
you.
you, sir.
I know even Bharti is contesting, and Bharti, I wish you all the best. Your passion is bringing you again and again to Foxy. And I think more than you need a Foxy, Foxy need people like you. Always remember that, whether on chair or not, you are always doing a great job and you will continue to do so. And we'll be fortunate to have you in Foxy. Yeah. So thank you so much. Placenta, accreta, abruptio. These are the great topics. Every speaker adds on differently. And I'm sure Parag, with his so much huge experience of near 35 years, will give a lot of practical tips, and I will also enjoy with you all. Thank you so much, and you can carry on.
Thank you so
Thank
much,
you.
madam.
Thank
Thank you
you
so
very
much for
much.
your appreciation as well as best wishes. Keep blessings always. Thank you so much.
Thank you.
Thank you.
Sonia, Anita, you people are great job, okay? You people coordinate very well.
Yeah,
Thank
they are
you.
really doing
Thank you.
great job. Yes.
Thank you, madam. As usual, you look good, beautiful on screen also. As usual, today also
Off
you're
screen, on screen.
on
both.
screen. Thanks so much.
I need to block Ajay Mane before he passes any comments. अजय के comments बहुत खतरनाक रहते हैं.
खतरनाक रहते, खतरनाक. Yes. Ajay.
Dr. Anita, do you recognize Dr. Hiremat join?
No, he hasn't.
No,
Checked.
he has not
So
joined. Otherwise, his
probably
screen
we'll
will be on.
pause when Dr. Hiremat joins in, and then we now
The
continue.
documents who have not named themselves. I don't know if sir is
Yes, yes, that's right.
the other name.
Neha, you have many people logged in, and I think cut short and go
Yes,
to the
yes. That
academics.
is the reason I started shorter. So please go ahead with Dr. Bharti, the President Ksoga, giving her precious words. And of course, then of course we have Dr. Ajay Mane, and straightway we go to the academic
Sonia,
stage.
Yes, ma'am.
We
please skip
keep the
this.
introduction for
Please
today,
go to the next
Dr.
page.
Sonia.
Yes, madam.
Yeah.
So we welcome Dr. Bharti Rajshekhar. There's one more true leader, inspiring leader of Ksoga, who's joined in as guest of honor, but we would like to hear from you, ma'am.
Namaste to all my dear seniors and friends. A very warm welcome from Ksoga to Amogs. We have our senior mentor here, Dr. Rajendra Singh Patesi, and of course we have Dr. Sunita Tandulwalkar, the vibrant president-elect, who is a leader and does inspire us in all her moves, whether it is in the academics or otherwise in her other activities too. And I thank Dr. Ajay Mane for having agreed to be on this webinar as a one of the chief guests. And Dr. Sneha Buyar is working day in and day out, 365 days, 24/7. And I'm sure, Dr. Sneha, your efforts will definitely pay good results. And we have our speakers, and as Dr. Sunita rightly put it, Dr. Parag Biniwale is a delight to the eyes as well as to the ears. And we are all here looking forward to hear from you, Dr. Parag, about how we could manage abruptio placentae without any morbidity and mortality. And of course, Dr. Sneha, as usual, she is there crisp and very clear in her panel discussions, and she will be talking to us on hyperglycemia and pregnancy. And what should I say about my mentor, Dr. Vidya Tope and Dr. M.G. Hirebhat, who will be joining us shortly. They are the guiding force for me, and always their blessings over my head, guiding me and telling me what is right and what is wrong, and trying to put me in the forefront so that I could showcase my talents and my academic proficiency in Foxy after my activities which they have seen in the Hasan Society and in the Karnataka State Society. And of course, Dr. Anita and Dr. Sonia have made our job very, very easy, along with Dr. Rajeshri, and they have been very instrumental in putting across these webinars. And I'm sure it is going to be a delight for all those who are going to participate. I thank all of you for being here on behalf of Ksoga as well as on Amogs, on behalf of Amogs. And again, I seek your blessings for my candidature as the chairperson of Perinatology Committee, and of course for Dr. Sneha Boyar as the Vice President of the West Zone. Thank you very much, and let us move on to the academics. And Dr. Ajay Mane will take over the microphone.
Thank you so much, ma'am. And in this platform, I again congratulate you, bringing laurels to Ksoga from Calcutta. And I now welcome Dr. Ajay Mane. Sir is on time.
Yeah, we'll
This
skip that. We'll skip that.
Yes, sir. This is the third session.
Thank
You're
you.
on this virtual platform with us, and we would like to hear from you, sir.
Yeah. Okay. Thank you. Start with, I must convey my gratitude to my sister, Dr. Sneha Buyar, who has invited me here as a guest of honor, though I belong to the family. So respected Hiremat sir, respected Sunita madam, respected Bharti madam, and the office bearers of Ksoga, respected Hiremat sir, respected Nagaraj sir, respected Vidya madam, respected Rajeshri Paladi madam, respected Suman Puri ma'am, and respected Durgadas sir, and our own Amogs office bearers, respected my brother Kiran, respected Bipin sir, respected Rajendra Pardesi sir, my mentor, and then Dr. Madhuri, and the lovely sister, Dr. Sneha. Today's topics are very important, as being Emergency Obstetric Committee of Amogs as well as Ksoga. Both are doing very nice thing, because these are the problems which are faced by all of the obstetrician and gynecologists in day-to-day basis. So we need to have all the inputs and the operative or the medical line of treatment ready in our hand. So it is a very nice CME. I give all the best wishes to the CME, and I give best wishes to my sisters, both Dr. Sneha Tai and Dr. Bharti ji. We want you both there as a chairperson and as a vice president, Foxy, by this time 100%, because Maharashtra and Karnataka, if they are united, nobody can beat the unity. So best luck to both of them and best luck for the web. Thank you very much.
Thank you. Thank you so much, Ajay. Thank you so much. I think
Thank you, Bhaia, for the warm wishes and the blessings.
Thank you so
Thank
much,
you
sir.
so much. We request few words of guidance for our mentor, Dr. Rajendra Singh Pardeshi, sir.
Yes. Good evening, everybody. Respected Chief Guest, Dr. M.G. Hiremat, sir, and our Iron Lady, Dr. Sunita Tandolkar, ma'am, Guest of Honors, Dr. Bharti Rajsekar, Dr. Ajay Mane, our Amogs President, Dr. Kiran Kuttakoti, Dr. Nagaraj, sir, Dr. Vidya Thobi, Dr. Rajeshri Paladi, Dr. Suman Gaddi, Dr. Durgadas Asarana, and friends. First, I wish to congratulate Dr. Sneha Boyar for organizing this important webinar on abruptio placenta and HIP. And these two topics are very important as they reduces maternal mortality. It's a major cause of maternal mortality, and we have to reduce maternal mortality to a single digit. So, with the eminent faculty like Dr. Parag Biniwale and all others panelists, I think this will be a great webinar. I wish every success to Dr. Sneha Boyar for her future endeavor in Foxy as Vice President for this in these forthcoming elections, and also to Dr. Bharti Rajsekar for her future endeavor as Chairperson of Perinatology Committee in this forthcoming election. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you very much, sir.
Thank you, sir. Thank you so much for your presence. Thank you. Over to you, Dr. Sonia and Anita.
Yes, ma'am. So Mohaj, and to bring wealth of knowledge and share the experience, we have eminent speaker on this virtual platform today, Dr. Parag Biniwale. For this session, I would like to invite chairpersons Dr. Shailaja Bidri and Dr. Mahananda S. Melkudi. Dr. Shailaja Bidri, Madam, my pranams to you. My own teacher, who's heading the Department of Obs and Gyn at Sri B.M. Patil Medical College, Vijapur. She is presently serving as an EC member of North Zone, Ksoga. Welcome to you, ma'am. And we have Dr. Mahananda Melkudi, whose contributions and visions have profoundly influenced the vision of women at various platforms through awareness programs and health camps. Madam is currently a professor in Department of OBG in Mahadevappa Rampuri Medical College, Kalburgi. Madam, we welcome you to chair this session and take the session forward. Over to you, ma'am.
Dr. Shaila, kindly introduce Dr. Parag Biniwale.
No problem.
Unmute yourself. Yes.
She is.
Good evening, everybody. It's a pleasure to be part of this program. I would like to introduce Dr. Parag Biniwale.
Some
Shailaja
problem
ma'am,
with
we
the
can't
network,
hear
I
you, ma'am.
suppose.
Obstetrics and
Yeah.
gynecology.
I think, ma'am.
Other chairperson can introduce if she
Permission.
has got any net problem.
Madam.
Hello.
Yes, ma'am. Now
Can you hear me, Sonia?
Yes, madam.
Hello. Hello.
Yes, madam. We can
Yes,
hear you,
yes, we can hear you.
Madam,
Yes.
can you hear me?
Yes,
Yes,
madam.
Shaila.
Okay. And National Website Editor, Foxy, 2011 to 2017. Peer Reviewer of Journal of Obstetrics and Gynecology, 2011 to 2017. Journal of Midlife Health. Chairman of Young Talent Promotion Committee, Foxy, 2008 to 10. And co-editor of book, Gynecological Manual of Adolescent Girls and Young Women, Year Book of Obstetrics and Gynecology 2019, exploring new version of Obstetrics and Gynecology, contributed articles to books and journals. He has got a lot of publications and other. Over to you, sir. It is very happy to be part of this.
So thank you. Thank you very much for those kind words. I bring greetings from Amogs, and as the national coordinator of Amogs, it's indeed a pleasure to interact with the members of Ksoga. So thank you, Team Amogs, and of course, I can't see the president, but the rest of the team, and of course, Team Ksoga, Dr. Bharati, the president, dear friend, Dr. Vidya Thobi, who's the immediate past president. And especially thank you, Sneha, for having me here to discuss about one very important aspect of obstetrics, and that is abruption of placenta. Right. So whenever we think of bleeding in pregnancy and any emergency which we don't want to face, and then the first thing that comes to our mind is abruption of placenta. All of us know that placental abruption refers to a partial or complete detachment prior to delivery of the fetus. And this typically, the diagnosis is reserved in pregnancies beyond 20 weeks of gestation. It is a significant cause for both maternal morbidity and neonatal morbidity and mortality, especially when it occurs in the preterm phase. Placental abruption fortunately complicates only 2 to 10 per 1,000 births, and we are lucky that we don't have to face it time and again. So typically, the patient will come to us with history of vaginal bleeding. She may experience abdominal pain, often accompanied by hypertonic uterine contractions. On examination, there would be uterine tenderness, and in most of the cases, the fetal heart rate pattern would be non-assuring, and in severe cases, we may be dealing with a baby who's already lost its life. Coming to the risk factors. So when we think of risk factors, we know that there are so many medical conditions which are by itself responsible for placental abruption, hypertension and hypertensive disorders of pregnancy being the most common. Premature rupture of membranes, chorioamnionitis, previous ischemic placental diseases are also responsible. But very importantly, if there is a history of abruption in the earlier pregnancies, it makes the woman prone for developing placental abruption again in this pregnancy. The million-dollar question is, can we predict abruption? Unfortunately, we cannot as of now, but of course, we can still do some investigations which may act as pointers for predicting abruption of placenta. So when we do all these serum biological markers which are used for diagnosis of Down syndrome and neural tube defect, so there could be a tenfold increased risk of subsequent abruption. So this is something which we have to keep in mind, and we should try and offer these tests to each and every woman who comes to us with a viable pregnancy. But what is bothersome is the severe abruption, because severe abruption is the one where more than one of the following complications of the mother or fetus or the newborn takes place. So the mother is likely to land up in hypovolemic shock. She may face the wrath of DIC. She may require blood transfusion. At times, she lands up in a hysterectomy. She may suffer from renal failure and even in hospital death. The fetus also suffers. There could be non-reassuring status of the fetus. There could be growth restriction of the fetus and death in some unfortunate ones. And as far as the neonate is concerned, many a time they are born too soon, and then they face challenges related to prematurity. They could be small for gestational age, and some of them even die after they are born safely. So it is extremely important that we monitor these patients carefully. So when we talk about monitoring these patients, the mother has to be monitored very critically, as well as the fetus. So we must initiate continuous fetal heart rate monitoring, because this is the baby who's at risk for becoming hypoxemic, and these are the babies who are likely to develop acidosis. So the first action we take is that we secure intravenous access. So place one wide bore, number 16 in the intravenous line. If the placental abruption is moderate or severe, it is worthwhile having two lines running simultaneously. So monitor this patient carefully, watch for her pulse, for hypertension, the uterine hypertonicity. We must also get the coagulation parameters also done and look for abnormal heart rate pattern. We immediately start administering crystalloids, preferably ringal lactate, to maintain urine output about 30 ml per hour. So close monitoring of maternal hemodynamic status is important. So ideally, if we have a monitor, it should be continuously monitoring the mother. So heart rate has to be monitored, blood pressure, monitor urine output by putting in a catheter, and of course, measuring blood loss is extremely important. So assessment of multiple parameters is important because normal blood pressure may mask hypovolemia if the mother has chronic hypertension or pregnancy-associated hypertension, which are the common risk factors for abruption. In patients who may have severe abruption, urine output should be monitored closely. A catheter may not be necessary if the patient is hemodynamically stable, but it is important if she's unstable, we should have it. Or if she undergoes a C-section, putting in a catheter is extremely important. As soon as we secure IV line, there are certain investigations we would like to send, which include complete blood count, including platelet count, because here we would certainly like to rule out consumptive coagulopathy. Blood should be sent for typing and cross-matching. Coagulation studies are important. So we look for prothrombin time, activated partial prothrombin time, and of course, fibrinogen concentration. Check for liver function test, renal function test, and of course, urine albumin. Here, we have to remember that if we are dealing with a woman who has preeclampsia or HELP along with abruption, it is important that the liver function tests are monitored very critically. The next important thing is to quantify blood loss. So moderate and heavy bleeding can be measured in a variety of ways. So first of all, you can collect the blood in graduated measurement containers, including drapes and calibrated pockets. Secondly, using visual aid, we always try and estimate the blood loss accurately. So don't undercalculate whatever blood has lost. It is okay to overcalculate because we don't want the mother to suffer. So measure the total weight of bloody material, subtracting the known weight of the same material when dry, and the difference in weight between wet and dry in grams approximates the volume of blood in milliliters. And actual blood loss may be far in excess of what is observed due to retained retroplacental, retrochorionic, or intraamniotic bleeding or clot formation. So the important take-home message is do not underestimate blood loss. Now, if the mother is unstable but with a live baby, she has to be shifted to a tertiary care center. If you are in a periphery or in a small setup, please don't manage her. It is vital that she is shifted to a tertiary care center where all facilities are there. C-section is probably the best option when vaginal delivery is not imminent. Blood and blood products for correction of hypovolemia and coagulopathy should be replaced prior to or during C-section. C-section is generally performed under general anesthesia because we don't want her to land up in hypotension after a spinal anesthesia. And presence of neonatologist or a person who's trained in neonatal resuscitation is very important. Now, if the mother is unstable with dead fetus, it means that probably more than 50% of the placenta has separated. So the optimal route for delivery in these cases would minimize the risk of maternal morbidity and mortality, because we know that fetal well-being is no longer a factor. Blood and blood product replacement are often necessary, and we must expedite delivery because the frequency of coagulopathy and continuous heavy bleeding is much higher in abruptions in which the fetal demise has taken place. Coming to the next situation, when the maternal condition is stable, but the fetal heart rate is non-assuring. So if it is a category 3 test tracing, we must expedite delivery, usually by urgent cesarean section, if the fetal heart rate suggests an increased risk of fetal acidemia. A biophysical profile of up to 2 to 4 also suggest an increased risk of fetal acidemia and the need for expeditious delivery. If the vaginal delivery is imminent, then a spontaneous or instrument-assisted vaginal birth is likely to be the least morbid route of delivery for the mother. For a stable mother with a non-reassuring fetal status, if the tracing is category 2, although a category 2 tracing may be managed by expectantly in patients without abruption, it is ominous in the setting of a probable abruption because of the high risk of sudden fetal deterioration to category 3 or even fetal demise. So delivery management would depend on the gestational age, the cervical dilatation, or whether there is a progressive deterioration in either the mother or the fetal condition. So close monitoring is essential, and we must prepare for urgent delivery in these expectantly managed cases. In a stable mother with a fetal demise, the decision about delivery should be individualized, taking into account factors such as gestational age and cervical status. Previous classical hysterotomy is relative contraindications for vaginal birth, although these patients are at increased risk of uterine rupture during labor. A 4 to 9% risk of rupture may be acceptable in the setting of fetal demise because cesarean delivery has no fetal benefit. So when we are dealing with a stable mother and a reassuring fetal status, so if the fetal heart rate pattern or biophysical profile is reassuring, then the decision to delivery vis-a-vis expectant management depends entirely on the gestational age and whether the abruption has led to spontaneous labor. Now, if we are dealing with a pregnancy of less than 34 weeks, if both mother and the fetus both are stable, there is no evidence of ongoing major blood loss or coagulopathy, conservative management with the aim of delivering a more mature fetus is the main goal before 34 weeks of gestation. So here we would like to administer a 48-hour course of nifedipine in order to achieve uterine relaxation, antenatal corticosteroids for all pregnancies before 34 weeks. You may add them even between 34 to 36 weeks because we know that it is not going to cause any harm, and in fact, it will reduce the chances of transient tachypnea of newborn. So contractions may be caused by direct or indirect effect of and may lead to further placental separation, which may in turn cause further bleeding, creating a cycle of bleeding and contractions. In pregnancies less than 32 weeks, it is prudent to administer magnesium sulfate for neuroprotection. So what to do when the woman is not in labor and she's preterm? So administer corticosteroids for fetal lung maturity and reduce complications of prematurity. So typically between 23 and 34 weeks of gestation, and even sometime later, it is given if there is increased risk of need of preterm delivery. Antenatal fetal assessment has to be vigilant, and fetal assessment with a non-stress test or a biophysical profile is performed at least every week. Serial ultrasound estimation of fetal weight to assess growth, since these fetuses are at a risk of developing growth restriction over time. What is also important in these women is counseling, because whenever you are treating them, we have to keep on talking to the patient and the relatives, and we have to reiterate the fact that we may have to take an urgent decision of delivery if something goes wrong when you are managing these patients expectantly. So the million-dollar question is how long the patient to be kept in hospital. So a reasonable approach is to monitor the patient in the hospital until the bleeding has subsided for at least 48 hours. If the fetal heart tracings and ultrasound examinations are reassuring, and if the patient is asymptomatic. The patient should be counseled to return immediately if she has further bleeding, contractions, decreased fetal movements, or even abdominal pain. And in patients with sonographic evidence of a large hematoma, it is prudent to keep the patient in the hospital for a longer period of time for close monitoring. So the question next is when to deliver these women who have history of abruption. So a patient who's managed conservatively and without any further symptoms, we must schedule delivery between 37 to 38 weeks because there would be an increased risk of stillbirth at a later date. Delivery before 37 weeks is indicated if there are additional complications like fetal growth restriction, preeclampsia, premature rupture of membranes, non-reassuring fetal assessment, and recurrent abruption with maternal instability. Placental abruption occurring in the second trimester carries an especially poor prognosis when there is accompanied oligoamnios, and this has to be counseled to the patient and the relatives. How to manage an abruption in 34 to 36 weeks of gestation? So delivery may be worthwhile in patients who have acute abruption at 34 to 36 weeks, since these patients remain at a risk of maternal or fetal compromise from progressive or recurrent placental separation, or neonatal morbidity is relatively low at this age. Partial abruption can progress to total abruption suddenly, and that too without warning. So the fetus should be continuously monitored and preparations must be made in case urgent operative delivery is required. Abruption with 36 weeks to term gestation, preferably it is prudent to deliver all pregnancies with suspected acute abruption at more than 36 weeks of gestation. This approach balances the relatively low neonatal morbidity to the near-term newborn in pregnancies and with the risk of serious maternal or fetal morbidity and mortality from progressive or recurrent abruption during expectant management. So we prefer a vaginal delivery if there are no obstetric indications for cesarean section. If there is a prior C-section or a malpresentation, we would straight away proceed with an elective C-section. With a clinically significant abruption, the patient is often contracting vigorously, but if she is not in active labor, then we can think of doing an amniotomy and administer oxytocin frequently, and this may even result in rapid delivery. It is extremely important that we continue taking her care in the postpartum period. In postpartum, an intravenous oxytocin infusion is given as the first-line uterotonic agent, and we also have to remember that the commonest cause of postpartum hemorrhage is antepartum hemorrhage. So this has to be very, very clearly understood in our minds. We have to monitor the mother very, very closely, monitor her blood loss, monitor her vitals, urine output, and of course, uterine size and consistency, because these are the women who are likely to bleed at a later date. Laboratory tests, including hemoglobin or hematocrit coagulation studies, are monitored closely to ensure that the bleeding has been controlled and the coagulopathy is resolving. And it will also help us to guide replacement of fluid and blood products if needed. Women who develop shock or disseminated intravascular coagulation are at a risk of multi-organ failure, especially acute renal insufficiency. So please keep a watch on urine output in these patients in order to prevent the complication of acute renal shutdown. And after delivery, organ function usually improves with aggressive supportive care and treatment of complications as appropriate. Before the patient is discharged, we have to counsel her, because if she plans to have a pregnancy in future, there would be a recurrence risk, and this could be as high as 3 to 15% as compared to a baseline incidence of roughly around 1% in the general population. Placental abruption, preeclampsia, and growth restriction appear to be variable clinical manifestations of uteroplacental underperfusion, chronic hypoxia, and uteroplacental ischemia. So close monitoring and appropriate delivery would be required even then. So to summarize, wherever we are dealing with a case of severe abruption of placenta, please manage it at a tertiary level center. presence of a senior obstetrician and neonatologist is a must. There have to be good level laboratory facilities, and all emergency care should be taken for the patient. And we have to have adequate blood and blood products ready. And then there are some don'ts which we have to remember. First of all, don't manage these patients in a small setup, especially the severe abruption. Do not underestimate the blood loss, because here you're causing a lot of damage to the woman if you don't substitute what she has lost. Don't rush into delivering an unstable patient. Make sure that she's stable, because you would land up in a blunder if she's unstable clinically. And don't miss out on small points in history, because even these small points would be of great help to saving life of the mother. So thank you very much. Once again, thank you, Amogs. Thank you, Ksoga. Especially thank you, Sneha, for having me here, and my best wishes to Sneha for her forthcoming elections, and of course to Bharati for her forthcoming elections. Thank you very much.
Thank you, sir, for a more informative and elaborated talk. And I would like to add one more thing. Patients should not go into irreversible shock. Many times they'll come in a late stage, and also blood components are not available, means they'll have a lot of problems. So only better to, you are conveyed that this message, you have to, patient has to be in a managed in a tertiary care centers, like medical institution.
Absolutely, absolutely.
Thank you,
So
sir.
you don't have to wait for the patient to deteriorate. The moment you suspect that she has abruption and she's likely to bleed, we have to ensure that she is in a safe and secure environment, where there are multi-speciality doctors available, all the facilities are available, there have to be blood and blood products available, neonatologist available if we decide to deliver the patient. So we can't take a chance and allow the patient to deteriorate fast. I would be happy to receive comments from Dr. Vidya Tobi. She's a senior professor and a popular teacher. Vidya, please add a few points to the presentation.
Absolutely, Dr. Parag, your talk was complete. And sometimes whenever we are screening for preeclampsia, we should always see that whenever we are doing sonography, or many times I have seen the patient with 130/90 also, the abruption happening. So there is some placental pathology, and there are many pathological or etiopathogenesis is involved. Second thing is about DIC score. Also, one should also be get acquainted with this DIC score. And as Dr. Shailaja was talking about the tertiary care management, so you must refer these patients as early as possible. We also grade abruptio into 1, 2, 3, 0, 1, 2, 3, and when the 0 will turn to 3, we don't know. So we have to really be very consciously manage these patients. There should not be any overloading also. Sometimes we just go on doing this, and the pathology worsens. So adding fuel to fire sometimes happens in abruptio placenta.
Absolutely.
So thank you very much.
Yeah, Dr. Vidya, you brought out a very, very valid point, because many a times we wait for the blood pressure of 150, 100, or even more than
Yes.
that to start antihypertensives. But now the current management protocols say that as soon as you see that the blood pressure is rising, you have to act really fast and
Yes.
control the blood pressure.
And sometimes in abruptio also the blood pressure is really we cannot judge on the just bleeding. So some concealed hemorrhage is there. So unless you have got ultrasound at your help, you really don't know how much is the bleeding at this places. So that is another thing. Yes. Blood loss estimation becomes a true, really, we cannot say that this much is lost. Yes.
Thank you,
Thank
Dr.
you,
Parag,
Vidya.
for that excellent talk.
Thank you.
And I think
Thank
we
you very
always have
much.
to listen to the patients.
Bharti wants to
I
add
just want to
something
say-
from her expert private practice. She has got a huge experience about the cases she
Pregnant
manages.
woman
Yes.
complains of either headache or an abdominal pain never neglect her symptoms. And even if her BP is normal or just hovering around 1,
Yeah, that's
be
what I was
careful
talking to.
about that.
BP can be normal also.
Yes, thank you.
And that is really sometimes bothers us. Yes.
So we have to listen to them, and whenever we tell them, though the fetal heart is okay and symptomatically signs may not be there, her symptoms may give us a warning. So we may have to admit them and keep them under observation if we have the facilities.
There's a question in the chat box. Is it safe to give steroids in a preterm abruption with hypertension? The answer is very much yes.
Yes.
So there's no reason why we should withhold steroids, because they would do far more benefits rather than any harm when we give it to a woman who's hypertensive but has abruption, because it will save a lot of challenges to the newborn, and it's not going to cause harm to the mother.
Thank you, sir. I think another chairperson, Dr. Mananda Malpulli ma'am. Ma'am, are you there?
Yes.
Can we have expert comments from you too?
Thank you for chairing this session, ma'am. Sir, I had two queries, but you have told in your talk it has been cleared, sir. Thank you for your informative lecture, sir.
I'm very happy that the people have joined across the country. I was just scrolling down how many attendees are there, though the attendees are less, but they are across the country. So I'm very happy about it. Thank you very much.
Ma'am. Thank you.
Yeah.
Thank you, ma'am. Moving on, I think we'll go ahead with the next section, that is panel discussion. As Dr. Sneha ma'am, I think Sneha ma'am is not there. I will request Dr. Vidya Thabi ma'am to take over this session.
I request Bharti also to join some of the in this panel discussion, as well as Dr. Rajashi Palladi, who is also a professor in a medical college. So she will also join in some of the question discussion. Please introduce all the panelists. Yes, please introduce the panelists, Anita.
Yes, ma'am. Yes, ma'am. The first panelist, Dr. Lokeshwari K. She is professor and unit chief, Basaveshwar Medical College and Research Center, Chitradurga, 9 years of teaching experience. Post-graduation from Guwahati Medical College and Hospital, Guwahati, Assam. And her fields of interest are obstetric emergencies and reproductive medicine. Sahitya, next slide, please. Dr. Soumya S., Associate Professor in, again, Basaveshwar Medical Research Center, Chitradurga, Diploma in Minimal Invasive Surgery, Fellow in ART, and 9 years of teaching experiences. Next panelist, please. Dr. Priyambada HP worked as an Assistant Professor in Subbaya Medical College, Shimoga, and she is having special interest in high-risk pregnancies and management, and actively involved in IMA and FOXI activities. Next slide, please. Okay, Dr. Arjun Kumar H, specialist. He is district member. He's from Mandya. Next panelist, please. Dr. Annapurna Dhanno, Secretary, the Society of Obstetrics and Gynecology. I think 2 or 3 panelists are busy with some emergencies. Dr. Sheila L, she is MBBS from KBN Institute of Medical Sciences, Gulbarga, and MS OBG from WIMS Bellary, and senior specialist in Maddur, Mandya district. Okay, next. Okay, we'll move on with the panel discussion. Over to you, Dr. Vidya Thabi ma'am.
You have to make me a co-host.
Sahiti?
Yes, ma'am. Just a second.
Yeah, make me a co-host so that I can share the screen.
Yes,
and these all slides are of Dr. Sneha Bhuyar. So I don't have, I will not defer anything, but because she might join, she's traveling right now. Hope my screen is visible.
Yes, ma'am.
Yeah. So out of these panelists, Dr. Arjun is here, Dr. Sheila is there, Dr. Lokeshwari is here. Anita?
Yes, ma'am.
Because they have not renamed them. So I have to ask them the questions, they should be there, no?
Dr. Annapurna.
So to make their videos on, please make the videos on so that I can ask them. Dr. Arjun was here. Yes, Dr. Arjun, welcome, Dr. Arjun.
Dr. Priyambada is also there, ma'am. I think Lokeshwari and
yes, welcome. Dr. Lokeshwari is here.
No,
I
ma'am.
don't, no.
Okay, Sheila, Dr. Sheila?
No, ma'am.
No. So Dr. Sheila is not there, Lokeshwari is not there. What about Annapurna?
No, ma'am.
So 3 people are not there. Soumya is there?
No, ma'am.
I'll just.
So only 3 are there. So I request Dr. Anita also to join this
Yes, ma'am.
important panel.
Sure.
Yes. So it is a nice panel, I must say.
Ma'am, please make it as full screen.
I'll be doing that. Yes. Hope you are able to see the screen.
Yes, ma'am.
Yeah. So we all know about Dr. Sneha, the dynamic our candidate for Vice President Foxy West Zone. And she is my dear friend, so she has asked me to do this panel. What we are talking is hyperglycemia in pregnancy. So this hyperglycemia in pregnancy, why we want to discuss is the incidence is slowly growing, and it is defined as we all know that it is first time when it is detected or diagnosed during pregnancy, we call it as a gestational diabetes mellitus. So they say that incidence is around 40% of the diabetic pregnancy who are unplanned pregnancies. But in rural and urban, definitely there is a difference. Might be the nutrition is playing some way or other. And there are other diabetes, means types of diabetes. We know type 1 diabetes and type 2 and then GTM. So as I was talking about the incidence is slowly growing, and 2 out of every 5 women of diabetes are of reproductive age, accounting for over 60 million women worldwide. Okay, so the prevalence of hyperglycemia increases rapidly with age and highest in the woman over the age of 45. We are talking about the pregnancy. So what is the impact of hyperglycemia in pregnancy on perinatal and maternal outcome, and why we are worried so much about hyperglycemia in pregnancy? Dr. Arjun, are you there? Yes. Anita, you can take this. Hello?
Hello.
Yeah.
Priyamvada here, ma'am.
Yeah, Priyamvada, you can take this.
Okay. The impact of hyperglycemia in pregnancy, mainly during pregnancy, the mother will have polyhydramnios. And
yes, you can talk of short-term impact and long-term impact. It is very easy to remember, and for the delegates who have joined. So you want to tell about the maternal complications? You can definitely tell. Yes.
Maternal complications, as I said, she will have short term, she will have polyhydramnios and difficulty in breathing because of polyhydramnios or macrosomia, and difficult delivery, sudden IUDs.
Yes.
And chances of cesarean section due to macrosomia are high.
Yes.
Long term, she will have chances of developing type 2 diabetes mellitus early in her age. And postpartum morbidity will be more like wound healing will be late.
Yes. So these are the short-term, we discuss into short-term impact and long-term impact. What we are worried is the transgenerational, the transmission of these disease. Okay, so about 50% of mothers of GDM, they definitely develop type 2 diabetes within 5 years. So what we always tell these women with GDM is to come for the follow-up in the postpartum period as well as every yearly. So annual follow-up of this GDM woman is also very, very important. And even the children who are born to this woman, they are also at risk of developing diabetes mellitus. So this is very important thing what we want to stop. So directly jumping into the case, this is a woman, she is 22 years old, primary gravida, coming for her first antenatal checkup at 10 weeks of gestation. And on examination, she is 152 centimeter tall and weighs 69 kg. Her BMI is 30 kg per meter square. she does not have any family history of diabetes. So, does she need to be screened for diabetes? If so, when? And what screening test is to be used? These are the two questions to be answered. So, even though she is not having any history of diabetes in the family, whether you will screen her. And if you are screening her, then we have to think of how you are going to screen and how what we will take up. Yes, Dr. Bharti, if you are there.
Ma'am, actually, this is hyperglycemia and pregnancy. I think we, as an ethnic ethnicity background, everyone, it should be a first step screening. So as soon as we are receiving, ideally, it is told 24 to 28 weeks. The
No, it is a
insulin
universal
resistance is
screening.
maximum.
Nowadays, we are
But
screening universally. Irrespective of family
screening.
history, we are going to screen universal screening. That is a definite. Because there are guidelines by FOXI, there are guidelines of all other international forums that we have to screen each and every woman, irrespective of her ethnicity or any family history. If there is no family history also, we are screening the woman. So now how you will screen?
OGCT 75 gram.
Yes. So that is a DIPSI test. Okay. So DIPSI test. So whether how you perform this DIPSI test with how much grams of glucose and what is the method? Whether Sonia wants to take up this question.
Irrespective of the ethnicity, whatever you said, whatever
Yes.
was the case presentation, a patient,
Yes.
when she is pregnancy positive and she is
Yes.
confirmed positive, the first thing we need to do is the screening. And the
Yes.
screening, by rule, it is 75 grams, 75 milligrams glucose. You dilute it in 300 ml of water and ask her to
Yes.
drink, wait for 2 hours, get her back after 2 hours, and do a blood sugar. And if it is more than 140, then you have done your screening religiously.
Religiously, this is a nice word. I appreciate this word. And there is no rule of doing this random blood sugar or fasting blood sugar or 50 grams of glucose. Okay, so we all follow the standardized test that is called as a DIPSI test, and even Government of India has endorsed this test. So it is done as Dr. Sonia has told, that is at the first ANC visit, whatever it may be in the first trimester. Then we repeat at second trimester. Earlier, we used to stop at second trimester. Now we do in third trimester as well, because many a times we get the positivity even in the third trimester. So first trimester, second trimester, and third trimester. And in first trimester also, many times that woman vomits. In spite of that, then you have to call her again and do it. So how to do the test? Dr. Lokeshwari, if she is there, or anybody else can take this test. Dr. Sonia has already explained. It is only one-step procedure, irrespective of previous meal, 75 grams of oral glucose load, and that to be a standardized glucose. And 2 hours later, we do the plasma glucose. And it is very simple, economical, and feasible. And it has come into the national guidelines for the diagnosis and management of gestational diabetes mellitus. Now, how you are going to interpret OGTT? Yes, Anita?
Ma'am, if it's more than 200 milligram per deciliter, it's diabetic. 140 to 199 milligram per deciliter, gestational diabetes. Again, 120 to 139, it is glucose intolerance. And less than 120 milligram per deciliter, it's normal.
Yes. So many times we see that it is between 120 to 139. And we see definitely in these women, the macrosomia and complications. So these also should be managed very meticulously. That's what we say. Now, what about HbA1c? How many of you do this HbA1c? We cannot call HbA1c as a screening test, right? So if the patient again had a fasting blood glucose is done, and if it is 86, but the HbA1c is 5.6, how you will interpret? That she is having diabetes, whether she is having GDM, and does she need to be tested again, and which test?
Madam, I think Dr. Arjun has got
Where is
connected now.
Arjun?
Dr. Arjun?
Yes.
Sir,
They
you
have to
can
make their
unmute.
videos on, otherwise I'll
You can
not know.
unmute, sir.
Madam,
Yes, sir is attempting,
madam,
yes.
madam, daughter
You
will
have to
answer,
rename yourself so that I will know that.
Arjun for H, madam, I am traveling this. A data to answer.
You're not
Network
able
is,
to answer this? Yeah.
madam, network is stable,
Achha,
madam.
your
Don't mind.
network is poor. Okay, okay, okay.
Okay, okay.
So you're
Don't mind, madam.
traveling? Yes.
Yes, yes, madam. Don't mind, madam, please.
What about Priyamvada? Anita, can you mute everyone?
I can't do it.
Saiti, I think you can mute Dr. Arjun. Sir, can you mute yourself, sir?
Yes, it is so much disturbing, Sonia.
Yes, yes, he's muted, ma'am.
Yes. So when HbA1c is 5.6, whether you will label her as a diabetes, she is diabetic. And does she have a GDM? Whether you will repeat her testing, whether you'll do DIPSI or OGTT in this patient?
OGTT, ma'am.
Yes, you will do OGTT and find out what is her fasting and post this one. The fasting they have given, but you will definitely load her with 75 grams and see the postprandial, that is after 2 hours. This again, the repeat testing was done for her at 26 weeks of gestation. And what DIPSI test showed was it is 168. So definitely it is more than 140. So we label her as gestational diabetes mellitus. So usually the management protocol is general management and medical therapy. So general management always consists of medical nutrition therapy, which is very cornerstone of the HIP. And the second one is physical exercise. And then comes the medical management like oral hypoglycemic agents and insulin therapy. Okay, so what is the treatment and again how you will review? What test you will do in the first trimester?
In the first trimester, we'll do her blood sugars.
Yes.
After that, if it comes as a positive, if she considered as a diabetic, then we'll first advise for NT&B scan, ma'am, at 11 to 13 weeks to look for nasal translucency mainly. And
yes.
After that, we look for her kidney function. Then how much is the sugars we'll evaluate.
Yes. Suppose her HbA1c comes very high. Whether you'll terminate the pregnancy?
No, ma'am. We'll start insulin immediately. And we'll go for early anomaly.
How you will do counseling and what is the importance of pre-conceptional counseling in these women?
Poorly controlled sugars, there is a very high incidence of chromosomal congenital anomalies.
Yes.
So if it is more than 10, the chances are 25% chances are there that the baby is going to have congenital anomaly, most of cardiac disorders.
Yes. So we have to again screen for this cardiac, this one by echo, at 22 to 24 weeks. That is the leave apart. But when other things are also very important, like evaluation of nephropathy, because many times we see that hypertensive disorders in pregnancy and HIP go hand in hand. So we have to screen for that also. And as you told, we have to do this biochemical screening and nuchal translucency in these women, no?
And to add on, ma'am, in the preconceptional counseling, already patient is previous delivery of diagnosed gestational diabetic, and she conceives
Yes.
again, or you're planning to conceive again, that preconceptional counseling screening is very important.
Yes. So that is very important. And as I was talking about the HbA1c, the rate of malformations, they increase as HbA1c also increase, but that is very, very not at all useful monitoring the sugar control during pregnancy. So we don't take that HbA1c as a reliable marker for screening as such. So these are the pre-pregnancy therapeutic goals as we were talking about the preconceptional counseling. Okay. So these are the things you should know whenever we talk of pre-pregnancy therapeutic goals. So American Diabetic Association that recommends value of 7% and ACE recommends a value of less than 6.5% to reduce the microvascular complication, retinopathy, nephropathy, neuropathy. And when the woman with diabetes and HbA1c is more than 10%, they should be informed about the complications. So they have to be advised to avoid pregnancy. They have to control first their diabetic parameters. They have to control and bring down that HbA1c down, and then only they should conceive. Okay. Now let us go to the case number 2, that is primary 16 weeks patient is diabetic. She comes to you with the following reports. That is, when the GCT was performed, it is 179 milligram per deciliter. So Dr. Arjun, if you are online, what you will do next? How you will be going to advise her about the diet, and whether you will start straight away with the insulin, or you will just put her on MNT and just leave her? And when you will call for again follow up for her testing?
Madam, I was going to do HbA1c. Hello. Hello.
Yes,
Hello.
we are able to listen to you, Dr. Arjun.
Okay, madam, we are going to do HbA1 also. Repeat the thing. Then the diet modification.
Yes, that diet modification, what you will do in the diet modification? What you will tell her to eat?
Cut down the carbohydrate content, madam. And mainly cut down the carbohydrate content. And if we're not going to control, we start metformin therapy, madam. Metformin, madam.
What you will ask her to control?
Carbohydrate content, madam.
Yeah.
Avoid
so
sugar.
The diet should be the carbohydrate control diet. No? Modifications are with the carbohydrates. Okay. So
yes, madam.
About you have to, when you are taking into BMI into account, we have to talk about the weight gain also. So she has to take the proper calories, and too much restriction also you cannot tell to the woman, because we are bothered about the fetal growth as well. So we have to first tell her what is her daily calorie count. So you have to take a diet recall from her, and then we have to distribute her calories. Okay. So for obese and non-obese, we have to differentiate and then give her proper advice. So how you will take in a dietary compliance? How much energy she should consume? I'm not able to listen to you, Dr. Arjun.
Madam, energy requirement during pregnancy is you are 3 types of there: center worker, moderate worker, heavy worker, madam.
Yeah.
Early requirement during pregnancy in sedentary worker 1,900 kilocalories plus or minus.
Yeah. So 350 additional calories we give in pregnancy, but for sedentary work we give the less calories. And these calories again will be divided into macronutrients, that is carbohydrates, fats, and proteins. So major chunk is from the carbohydrates. And you always remember the diabetic plate. And diabetic plate has got 4 portions, right? One is vegetables, one is proteins, one is carbohydrates, like that. And this again, energy requirement is divided into the weight category also. Okay. So when we call the woman as obese, that is more when the BMI is more than 25.
25%.
Yes, yes. So this is what I was talking about, the plate, isn't it? This plate has got carbohydrates, proteins, and you have to split whenever we are asking her to take breakfast, you have to split the breakfast in carbohydrates. So we have to again think of vegetables, many raw vegetables. If you can give her, then that will definitely reduce, and additionally fibers. Okay. So they always tell about the palm size portion of the healthy protein, fist size portion of the starchy fruit. So these you should tell, and exchange, carbohydrate exchange is very important. Okay. This is very nice, the FIGO recommendations. One is very important is frequent follow-up and the antenatal care with GDM trained healthcare provider. That is very important. And whether they can monitor their own blood glucose. We have to teach them how to monitor. So many of the women are educated and they have that AccuCheck at their home. So they can monitor their fasting, postprandial, and how many blood sugars you will tell her to do. And what about exercise? Let us move ahead and find out about the exercise. Walking is the best exercise. Do you agree?
Yes.
Sahiti, can you mute everyone who are talking? Yes. Dr. Arjun, can you tell something about exercise, what you will advise to the patients?
Simple exercise, hip exercise and arm exercise.
Yeah. So you cannot tell them to do vigorous exercise. They have to
Vigorous
start for
exercise.
30 to 45 minutes and then you have to gradually increase to 45 to 60 minutes. So it is very important. Even sitting on the chair, simple movements, simple things you can tell to the pregnant woman to have a good compliance with the patient. So brisk walk, household work, or simple arm exercises you can ask them to do. And that physical activity should be for 30 minutes per day. Okay. So any maternal monitoring you will do with MNT. So even if you advise at the first stage, the medical nutrition therapy, so you have to advise this for at least 2 weeks. And again, you have to repeat her 2 hours postprandial glucose. And again, if it is normal, monitor this every month in second and third trimester. And this fetal monitoring is very, as we are doing in non-diabetic pregnancy, you have to do. So if 2 hours PP postprandial plasma glucose is more than 120 milligram per deciliter, you can start with insulin or oral antidiabetic. So which oral antidiabetic you will give?
Metformin.
So metformin can be given and metformin can be safely given. So metformin is advised by the Government of India guidelines also. Now, what about this case 3? This is primary 20 weeks. Parents are diabetic. She comes to you with the following reports. Fasting is 95 and postprandial is 175. What you will do next? Dr. Annapurna joined? Yes. So our target is always, now in this patient it is 95, okay. Our target is less than 90 and postprandial should be After 2 hours, it should be less than 120. So we have to monitor the postprandial, and here it is 175. So what you will do? Again comes with the diet again, with the exercise, and if there is no control, then you can start with insulin. Now, this pharmacological management is very important. If the lifestyle modification, it is not controlled, then we can start metformin, or you can do give insulin. With metformin or insulin, again, we have to teach every patient the self-monitoring of blood glucose. So how you will do? 3 to 4 times you have to monitor the blood glucose. One is fasting once daily, followed by at least 8 hours of overnight fasting. Then postprandial 2 to 3 times daily. So 1 to 2 hours at the onset of after the onset of the meal, and rotating. First you can do after breakfast, then second day you can do after lunch, and third time on different days of the week. So this can be done, and then this can be monitored with the glycemic targets and the weight gain. So our guidelines say that metformin or insulin therapy is the accepted medical management of pregnant women with GDM, not control on medical nutrition therapy. And insulin is a first drug of choice, and the metformin can be considered after 20 weeks of gestation. Though we know that there is a MIG trial, they have done many studies, but even then, and metformin is easily available, and people at the periphery, they are very much afraid of giving injections. So metformin can be given safely after 20 weeks of gestation for the medical management of GDM. So can somebody talk of oral anti-diabetic agents in GDM? Either metformin, glyburide, or acarbose. What is acarbose? Yes? Anyone? Anita, can you take this? The guidelines are different, okay? So some people, they directly start with the insulin or oral agent. They say that only oral agents can be started. Some guidelines say that only insulin is preferred. And some people, they say that even IDF says that metformin and glyburide are safe. So these things are different. But in our country, they say that till 20 after 20 weeks, we have to
Metformin can be
consider.
started after metformin.
Yes. So these are the various guidelines, they differ with each other. So oral anti-diabetic agents, combination therapy with insulin also can be tried. If it is not controlled with metformin, you can add with the insulin. Okay. So if it is not controlled, you can add with metformin also. So both can be started, and MNT, of course, is a major you have to cornerstone, means all patients with gestational diabetes or type 1, type 2, anything, you have to first start with MNT. When you will start insulin?
When sugars are not controlled with medical nutrition therapy, or the
Yes.
first sugars only are diagnosed with
If the patient comes with
high.
a postprandial blood sugars as more than 200, then directly we should start with insulin. We will not start MNT, wait for 15 days, again do the sugars. No. When it is more than 2 hours postprandial blood sugar, more than 200, definitely you have to start with this one, insulin therapy. And which insulin you use? This already we discussed how many times, so how frequently you should monitor the blood sugar levels. Okay, you always do this plasma blood glucose levels, and teach every patient the self-monitoring of the blood glucose levels. Okay, so these plasma glucose are very changing, no? So if you can monitor yourself, or you teach the patient that you can monitor these very easily yourself, so they definitely learn very easily. So there should be a 4 tests for the diet treated cases, 1 fasting and 3 post meals. And earlier we used to do 7 tests if the insulin is given. And how in your practice, how you do, Anita?
Earlier, what you were telling about 7 point sugars is one at the fasting blood sugars, then all three meals, that is pre-lunch, pre-dinner, and post-lunch, post-dinner, and post-breakfast also, and midnight one at 3 a.m. to that rule out that
So this
homeopathy
is not
effect.
practical, no? If you are telling the patient to do this 7 tests, it is very
So it-
difficult. So practically 4 tests in any other
4
2 days a
tests.
week, you can advise these patients. Okay. So what about the maternal and fetal surveillance? What surveillance you will do? If you are giving insulin, if you are giving metformin, and suddenly you detect there is a polyhydramnios or macrosomia, that means your sugars, the patient's sugars
Sugars
are
are not
not
controlled.
at all
Not
controlled.
controlled.
Yes. And also the anomaly scan in diabetic patients is very, very important, isn't it? So monitoring of the blood sugars, do the optic fundi for the retinopathy, creatinine is very important for the nephropathy. And at 18 to 20 weeks, you do the fetal echo, and that is a 4-chamber view with outflow tract for all women of pre-GDM. And 20 weeks anomaly scan is very, very important. So many congenital anomalies we see in these all babies,
Diabetic
no?
mothers.
Diabetic babies. So what are the most important congenital anomalies you see?
Cardiac anomalies are the most common ones. Yes,
Yes.
yes, doctor. Yes, madam, please tell.
Yeah. Please rename yourself so that I can call you. I will not be able to recognize you if you have not put your video on. Yes.
Yeah, mainly cardiac anomalies we'll find in GDM, ma'am.
Yeah.
Other than in that VSD will be more common. Other than that, cardiac anomaly will be there, but it is very rare.
Yes. Cardiagenesis, all those things are there. That's why the screening and monitoring of the fetal growth as well as any development of polyhydramnios and other things we have to monitor. And main important is the monitoring of the blood sugar. And also, as I told that hypertensive disorders are also common. So proteinuria and serial uterine fundal height for any fetal growth restriction. So whenever we detect fetal growth restrictions, just suspect that she might be having hypertensive disorders as well simultaneously. So this growth scan should be at 28 weeks, 32 weeks, and 36 weeks. And if there is a placental insufficiency or development of hypertensive disorders, and more frequently. What you will do about the NST? NST and Dopplers.
NST weekly after 32 weeks.
Yes.
Fetal Doppler, if there is IUGR, then we have to do by once in 2 weeks fetal Doppler.
Okay. Okay, that is there. Then let us move to now case 4. Okay. Primary gravida, 33 years old, 7 years of infertility, obese, PCOS, conceived on treatment, continued metformin, diagnosed GDM at the first visit itself, which was controlled on MNT. HbA1c, it is high, that is 6.9 at 33 weeks. And you find there is a macrosomia on the ultrasound. What things must have gone wrong? How you will manage?
First thing was her age. She's 33 years is a significant age. Second thing was her 7 years of infertility. Whenever there is subfertility, there are chances of insulin resistance. Third thing was her obesity and PCOS. Both are high risk factors for development of gestational diabetes as well as type 2 diabetes.
Yes.
Next thing was when she was diagnosed with GDM with so many risk factors, she should have preferably started on insulin looking at her sugars.
Yes. So immediately she should have been put on this one insulin only, because metformin again takes time, isn't it? So
Yes, ma'am.
first they should have done this testing properly, monitoring properly, And then fetal well-being and maturity was not at all properly monitored because there is a development of again macrosomia.
Yes, ma'am.
So whether you will give steroids in such patient?
Yes, ma'am. Diabetes itself is a risk factor for there is a poor surfactant development. Insulin inhibits the surfactant development at a very molecular level. So
Yeah.
the actually fetal maturity is considered at 38 weeks rather than 34 weeks when they are diagnosed with gestational diabetes. Along with that, poor control of sugar is there in this patient. So steroids should be considered.
Yeah. So whenever we are giving steroids, there is always means a rise in the blood sugar levels, no? So steep
Yes,
rise
ma'am.
can occur. So we have to monitor carefully. We have to increase the insulin dosages. This is very important when we give the steroids. Okay. And
Whenever we are
delivery.
administrating, yes,
Yeah.
adding on, whenever we are administrating steroid,
Yes.
we see a sharp rise in the sugar levels after 12 hours of administration of the first steroid, and this will persist up to 72 hours. So in that
Yes.
duration, if she's in the hospital, it is better for her to be in the hospital with insulin increase with 10% insulin increase. And there are also very high chances of reduced daily fetal kick count. So both should be simultaneously monitored
So
in the
whenever
hospital.
your interpretation of NST is there, no, that also you should consider. Whenever you are giving steroids, definitely that NST also comes very vague. So you cannot give interpretation should be done properly for those women. Okay. And as you told, there is a 10% rise of, you can 10% increase in the insulin dosages. And then delivery should be planned at 38 weeks by cesarean section, considering the complication with macrosomia. So this is a macrosomic baby. And how you will see on ultrasound, how it will help in detecting? So how they are
Yes,
telling
ma'am.
that, yeah.
Abdominal circumference is more than 75th percentile for that is gestational age. And even a growth curve, when it plotted, it will move to the upper normal rather than being in that growth curve, the growth scan, which we say.
So serial scan is very important, and though it has got a limited sensitivity to detect macrosomia, the abdominal circumference is the what we consider whenever we talk about macrosomia. What about Doppler in a woman with diabetes in pregnancy?
We, as you have told that, and we know that hypertensive disorders in pregnancy and diabetes most often they coexist because they both have the same risk factors like obesity and all. And if we and when diabetes is having vasculopathy, again there is a Doppler change. We should suspect that there is fetal insufficiency.
Yes. So for mainly we do Dopplers for the prediction of preeclampsia, but when we suspect there is a fetal growth restriction or placental insufficiency, definitely Doppler is helpful. Now let us come to case number 5, who is a gravida 2 para 1 with no abortions as such, but she is elderly, that is 36 weeks with previous one section. Now she is 26 weeks pregnancy, which she is diagnosed diabetic in the 3rd month, and she is on insulin. Her HbA1c is 6.5 of 150, 90. Clinically small for gestational age. Now here it comes. No, hypertensive disorders as they have detected that it's a small for gestational age. And how you will manage this? Manage this patient.
Since her BP is also in the higher range, we will have to, after monitoring the BP, we will have to start with antihypertensives.
Then
There
is a growth restriction also. So there are many multiple risk factors. She's elderly, previous section, GDM, then HDP, and growth restricted baby. So all these are very difficult to manage, but we have to screen the biochemical markers, then biophysical markers, and T-scan, then we have to do cervical length, because these women are prone for preterm labor, isn't it? And then we have to do the combined use of various biomarkers and uterine artery pulsatility index, and then target scan with the 4D color Doppler ultrasound to rule out any congenital anomalies. They are very, very common. And then she is also previous section. So we always know that the placenta accreta spectrum diseases are very, very common in these patients. So how you will monitor the control of diabetes? Now we discussed about we are not going to do that
We're not doing
7-point
7-point
testing.
sugars.
Yes, we are not going
Yes,
because
ma'am.
it is very cumbersome.
And target sugars, yes, ma'am. Target sugar should be fasting
Yeah.
less than 90 milligram per deciliter and postprandial
120.
120 milligram per deciliter.
Yeah, 2
HbA1c also
hours
should be
one,
less
less
than,
than 120.
ideally to be less than
Yes.
120.
So for practical purpose, at least 2 tests daily before breakfast and 1 at the night before bed. And then of course, when it is stable. So at least 1 fasting, 1 post meal for each meal 4 times a daily initially. And then that can be repeated any 2 days of the week for the monitoring purpose. Okay. So maternal monitoring, we have discussed about the control of blood sugar and then control of blood pressure as doctor told about the antihypertensives. Okay. So another thing is she is having hypertensive disorders in pregnancy. So definitely we have to monitor her liver enzymes and kidney function test weekly. Okay. So fetus is growth restricted. So we have to keep a close watch on growth and biophysical profile. Definitely, yes, that about the antenatal steroids, whether you will give magnesium sulfate.
If we are planning to deliver her early when there are two major disorders like diabetes and hypertension, I would like to
Yes.
consider from
When you
28 to
decide
32
to
weeks.
deliver her early, then only you give magnesium sulfate. Otherwise, not needed, isn't it? 150, 90, we don't give magnesium sulfate for as a prophylactic dose. But for the neuroprotection, definitely yes, when you want to terminate her pregnancy for the high BP and other complications like GDM and previous cesarean. Okay. Now, this is a case number 6. She is a known case of GDM managed on insulin, and she has come for at the 36 weeks. Okay. So whether you'll deliver this patient at 36 weeks?
Ma'am, at 36 weeks, like we've told that if medical and nutrition therapy, if it is controlled, then definitely we want to wait till 38 completed weeks. If she's
Yes.
on insulin and still controlled again, or metformin and still controlled, we want to still consider delivering her at term. And if it is uncontrolled, then she needs to be in hospital monitored. And if still not controlled, then we should plan for termination of pregnancy.
Yes. So you means you have to categorize, and it is an individualized treatment. So if she is controlled, not controlled, and whether there are any other complications she's having like polyhydramnios or macrosomia or any additional retinopathy or nephropathy or other diseases which are accompanying, then previous section, all these matter, and also the fetal weight also matters. So you decide on that, and of course the pelvic assessment should be done, and then decide about the induction of labor or elective cesarean delivery. So this is all dependent on the how is the glycemic control, any fetal compromise, and sometimes the woman can go into the spontaneous labor also. So how many of you really induce a diabetic woman at 38 weeks?
I think it
So
is again
now we
individual
say that
decision and the
39
weight of the
completed
baby.
weeks. Yes.
Yes, ma'am.
We
Yes,
want
ma'am.
a good outcome also, no? Neonatal outcome. So we always talk of completed 39 weeks whenever we do the induction or termination of pregnancy. We talk of 39 weeks, then the 38 weeks. Okay.
Yes, ma'am.
So that's what we talk on
Yes,
in the absence of obstetric or any diabetic complication. So we want good neonatal outcome. So we always talk of 39 completed weeks. But even earlier than that, it is 38 weeks, not less than that. Okay. This is a case, 6th case we are discussing, that is 36 week, known diabetic. She comes in labor. blood sugar was 140, but that was postprandial, and she was on insulin. So she was taking insulin 12 and 6. How frequently you will monitor her? Dr. Arjun, are you there?
Yes, madam. You monitor.
How you will monitor during labor? Whether during labor the insulin level means insulin, whatever the requirements are less?
During labor, actually, it's more, madam.
No.
Hello?
During labor,
Madam,
the insulin, yes, insulin. No. Whenever we during labor, the insulin means requirement go down. This you remember, because insulin levels means the labor is an exercise. So during exercise, levels will drop down. Okay. So
yes,
also she needs the hydration, and we want to avoid the ketoacidosis. Okay. So how you will manage the labor?
madam, the monitoring of the glucose every 6th hourly, madam. But NST we are doing repeatedly, madam. The fluid management you have to do that, madam, by using a normal saline or DNS.
So you are not audible, Dr. Arjun.
Madam, we are doing after 4 centimeter, we are doing partogram.
Yeah, so partograph is a must for any patient, and especially when the diabetic mother is there, the partogram is very, very important. And the monitoring of the blood sugar is very important. And how you will give the insulin, if she requires the insulin as per the blood sugar levels, we are giving her insulin. And the insulin requirements during labor definitely drop down. And the maintenance of hydration also is given. But what about the elective cesarean section is planned? If the baby is macrosomic and she has completed 39 weeks, well controlled, diabetes is well controlled, then how you do the cesarean section?
Madam, you are monitoring the blood sugar level by below kept RBS should be less than 105, madam. That much you have to under.
No, I was asking about the elective section. Whether you'll give the morning dose.
Yes, madam.
No, morning dose is skipped. She will be started on normal
Night
saline
dose is
or
given, ma'am. Morning dose is skipped.
Yes, night dose is given and morning dose is skipped, and later
Morning
on it
again,
is given according
RBS.
to the.
Yeah, as soon
Yes.
as we are taking
So
her for
you.
OT, we can do RBS and ketone bodies if we should not land up in
Yes.
ketoacidosis. And then we can, depending on the blood
Yes.
sugar levels, we can be giving her NS or DNS or any infusion.
Yes. So again, you have to do the sliding scale. How much is the sugar? Okay. So they require monitoring. Okay. This is, and even for the induction of labor also, morning dose of insulin is withheld. And again, you have to monitor the labor. Okay. Now, how you will monitor the sugar levels? This is what we follow, the sliding scale. If it is between 90 to 120, no insulin is added. 120 to 140, 4 units. 140 to 180, 6 units. And more than 180, it is 8 units. So you have to, if you have got an infusion pump or something, you can infuse, or you can just give on drops per minute. So that usually we give like this into the sliding scale. So how you will do the postpartum follow-up?
Again, third day we have to third postnatal day. I think we have to repeat her immediate postpartum. We are going to depending on most of the gestational diabetic patient will resolve, and her sugars will be within the normal limits. And once she starts taking regular diet, we can again get her fasting, and the postprandial blood sugars should know the control. After that, she has to be again assessed at 6 weeks. Once her her postpartum period is getting over. Again at annually and triannually, she once in 3 years she has to be assessed. And if she is planning for next pregnancy, pre-pregnancy, again she has to be evaluated for her diabetes, because gestational diabetes, 15% of them will become type 2 diabetes mellitus within 5 years. So depending on that, we have to continue the follow-up.
Yes. So follow-up is very important. Breastfeeding is also important. The breastfeeding itself will reduce her sugar levels. And then the contraception, which you will advise? You know na MEC wheel. MEC wheel रहता है ना, तो we accordingly you can give whether you want to give a combined hormonal this one contraceptives, or you will give barrier methods, or whether you will give her implant or LNG-IUS or copper T, what you will give?
You can advise for copper T and barrier
Yes.
methods.
Mm.
I think
Okay. So they say that copper T or LNG-IUS can be inserted, but LNG-IUS is costly. So usually we advise them the copper T, which is very commonly inserted. Okay. Now, these are the guidelines of ADA, that is American Diabetic Association, and they say that insulin is a preferred treatment. Metformin should not be used as a first line. It definitely crosses the placenta. And if it is used for the treatment of PCO and it induces ovulation, should be discontinued at the end of first trimester. So this is how the guidelines go. The universal testing first at the first antenatal visit, 75 grams at 2 hours plasma glucose. If it is more than 140, manage as GDM. If it is negative, less than 140, repeated for 24 to 28 weeks. Again, if it is more than 140, manage as GDM. And negative, then you have to manage as a normal ANC. So this is a chart which is given in the Government of India guideline, and we always follow this, and you can also put it at your desk. Very easy to follow, and very easy to remember also. So if Dr. Anita, if you can read it out for the delegates, it will be good.
Yes, ma'am. Pregnant women with gestational diabetes mellitus, if medical nutrition therapy, if 2-hour postprandial blood sugars are more than 120 milligram per deciliter, start human insulin premix 30:70, subcutaneous injection 30 minutes before breakfast once a day. Dose of insulin should be calculated by blood sugar levels. If the second 2-hour postprandial blood sugar is less than 120 milligram per deciliter, and she's on medical nutrition therapy, continue that therapy. Again, if it is less than 120, continue MNT and physical exercise. Repeat 2-hour postprandial as per high risk pregnancy protocol as advised by the physician at least once in a month. More than 120, again she falls in the first category where insulin should be started. If it is less than 120, continue medical nutritional therapy. Again, blood sugar between 120 to 160, dose of insulin should be 4 units. 160 to 200 milligram per deciliter, dose of insulin 6 units. More than 200, it is 8 units. Fasting blood sugars and 2-hour postprandial blood sugar every third day it should be done. Fasting less than 95 and second hour postprandial blood sugar less than 120. Continue same dose of MNT, continue same dose of insulin plus medical nutritional therapy and physical exercise. Next category is fasting blood sugar less than 95 but postprandial more than or equal to 120. Increase the dose of insulin by 2 units pre-breakfast plus MNT and physical exercise. Third category, where both fasting and postprandial blood sugars are more, then give injection insulin in 2 doses. Same dose, 2 units pre-breakfast and 4 units pre-dinner. Repeat fasting and 2-hour PBBS every third day till the dose of insulin is adjusted. Again, the category continues. Both fasting and postprandial are controlled. Continue same dose of insulin, MNT, and physical exercise. Fasting less than 95, but postprandial more than 120, or fasting and or both fasting and postprandial are not controlled. In such cases, repeat fasting blood sugar and 2-hour postprandial every third day. Add 2 units pre-breakfast if PPBS is raised. Add 2 units pre-dinner if FBS is raised. till desired levels of 90 fasting 95 and postprandial 120 are achieved. Continue same for all others. Whenever it is controlled, you have to continue the same dose of insulin along with MNT and physical exercise in all cases.
Yes. So, and very important is which type of insulin use. So, insulin is always a premix 30 by 70 to be used, and the insulin syringe, or sometimes they use pen also, but we have to tell them where to take the injection properly, and that should be a subcutaneous injection only. So, this chart is very self-explanatory, and how often it should be. You have to repeat the sugars. So these are the key messages what we have learned by this panel. That is advocacy and adherence to the protocol for the testing. That is always a universal screening for all women irrespective of anything. Then you have to talk of universal testing for every patient. Maintain one register that how many of them really take this 75 grams exactly, and the laboratory how you are going to test it, and that whatever the meter you are using, that should be properly calibrated. That is testing machine what you are using. To all pregnant females, use a single step procedure and follow the lifelong lifestyle modification they should follow. So it definitely makes a revolution in the treatment of diabetes, and definitely in our country they say that there is a tsunami of diabetes, and we have to manage. Mainly we have to modulate our medical nutrition therapy. So we talk of insulin as a drug of choice, and metformin, even when already if I started for PCOS, we always continue. They say that it should be stopped, and again insulin should be started. There are many studies also available, like as I told, MIG study, but they have not found any effects on the means the baby on follow-up. So those people who are not willing to take insulin are not very friendly, then you can definitely continue about this insulin therapy. Okay. So I'm very thankful. And just Anita, if you can call our Dr. Sneha, if she wants to have some comments, I would love to listen from her about any panel or any expert comments. So each one of you give some take-home messages.
Madam,
Can
with
anybody talk
your
on this? And there is an emerging role of again probiotics. Probiotics in whenever we are talking about medical nutrition therapy also, isn't it?
Yes.
And about the insulin therapy, we remember that in first trimester it is 0.7 units per kg of ideal body weight. Second, it becomes 0.8, and third trimester we give 0.9 units per kg body weight. And in obese women, they may need additional means 1.5 to 2 units to overcome the combined insulin resistance of pregnancy and obesity. So remember that 2/3 of insulin is given before breakfast as 70-30. That is, you have to give 70 intermediate and 30 regular, and 1/3 before dinner. That is 50-50 intermediate and regular. So that you remember. And target plasma, we have already talked about 90, and 2 hours postprandial, it is 120. Okay. Yes.
Madam, with your permission, can I add on? It is
Yes.
Just a summary. I think Dr. Anita, did you get Dr. Sneha through?
Hello.
Sneha must be traveling.
Yes,
Hello.
yes.
And
Hello.
I just
Hello.
want to talk about some GDM card which is available. And it is really sometimes a family. We should teach the family. And we cannot become dietitian, lifestyle expert, or endocrinologist, or diabetic educator. Everything is not possible by obstetrician. But some part we have to take up and really teach this GDM woman how to tackle. Okay. So this I just want to take home message. And just call Sneha, and if she can.
Yeah, she is actually logged in, ma'am.
Yeah.
Hello.
Yes, madam.
Yes.
She logged
Yeah.
in.
So
Sneha, we
yeah, I
just
just done all
finished.
the formalities, and I'm now here. Okay, I think Vidya has done a wonderful job, and I mean, she's the boss. Nutrition,
I'm not the
diet.
boss.
Yes, definitely. I mean, practical counseling, nutritional education. Who else can be the better person to talk about this? And thank you, Dr. Vidya, uh, for taking over a responsibility and to go ahead. Thank you so much. And I could hear the initial part also and the last part also. The panelists have actually done very well. And I think, give only this message that whatever you have discussed, you have to make a point that it should be universal screening every pregnant woman during every pregnancy. That is how it should be. And the screening method has to be universally or unanimously accepted. 75-gram single step OGTT. There should be absolutely no disparity in our thoughts. It should be very, very clear. And of course, you have to test it or screen the patient at the earliest, that is, at the very first point of antenatal contact. If that is negative, then you have to repeat it at 24 to 28 weeks. If at all, at any of the occasions, she is um, showing equivocal, that is, gestational glucose intolerance, you have to give her dietary advice, and you must repeat that screening even during third trimesters between 32 to 34 weeks. So that is what is the message. Though insulin remains the first drug of choice, now that it has been proven beyond doubt that for a low resource country like India, metformin is equally safe and effective. So we can very well go ahead with metformin. After 20 weeks, definitely for sure, you have to just try to avoid the first trimester because the safety is not proven beyond doubt. So I think that should be all from my side. GDM has to be looked after. Veda has discussed it very well, that why you want to screen, because there are short-term implications, not only effect on maternal mortality, morbidity, but also on perinatal morbidity and mortality, and the long-term effect of over diabetes in mother and metabolic syndrome and diabetes in the fetus or the baby which delivers later on. So the screening is most important and it is a must. I think that is all from my side. Thank you so much. Thank you so much, everybody, for bearing with me.
Thank you, Sneha.
Thank you so much once again.
Madam, with Dr. Sneha's permission and moderator Dr. Vidya Thube's permission, to summarize and conclude, it was an excellent panel. And just to add on, and there were a few queries, and just to add on about magnesium sulfate. So we just want to make it clear that with the papers, what is published recently, it is only for neuroprotection and not for lung maturity, magnesium sulfate, because it is given only to avoid a white matter injury. And it should be before 32 weeks. And the effect is only before 32 weeks. So whenever I am counseling my patients of GDM, there are two numbers which we actually run through. It is BP, everybody knows it's 120/80. So we also tell the diabetic patients as 120/90. So it is very easy to remember 120/80 as BP and 120/90 of postprandial and then fasting levels when we are checking on it. And another important point I was thinking is the calibration of the machine they use for checking is very important. In a house, if they are actually 3-4 diabetics, they are using the same machine. It carries a memory itself. So that also is an implication where they have false figures on the machine. So calibration is important. We need to educate them how exactly the insulin has to be taken subcutaneously. This education is very, very important. And the discharge summary should mention the dates of the following follow-ups with, as Dr. Vidya ma'am rightly said, with the contraception, whether the patient is going to come to you for follow-up or not coming to you for follow-up, the discharge summary should be mentioning about the follow-up dates and the contraception. With this, I think this was an excellent HIP. Then if we call it as GDM, it is G, we say it's guidance, by D, the doctors, M for monitoring, And this panel has done an excellent job on monitoring the diabetic status of a pregnant lady. And we are all here just to get the next population, diabetic free population. Thank you so much, ma'am. Over to you, Dr. Anita.
Thank you, ma'am. I think we had a wonderful session with under the guidance of Dr. Kabi madam and also Dr. Sneha Bhuyar ma'am. Moving on, we've come to the end of. So I'll be requesting Dr. Suman Gaddi ma'am, who is already joined and who is here with us throughout. Ma'am, please deliver the vote of thanks.
Yeah, good evening, one and all. First of all, I would like to thank Dr. Sneha Bhuyar for organizing such a wonderful webinar for all of us. I would like to thank the entire Ksoga team and Amogs team for coming together for this webinar and making it so successful. I thank the chief guest of today's webinar, Dr. Sunita Tandulwalkar, guest of honors, Dr. Bharti Rajshekara and Dr. Ajay Mane for their pearls of wisdom. I also thank the speaker, Dr. Parag Biniwale, who really spoke so well on abruptio and how to manage abruption in a safe and secure environment in order to reduce the maternal morbidity and mortality. That was very wonderful. Then, of course, the panel discussion wonderfully moderated by Dr. Vidya Tobbe, and the panelists did well, Dr. Arjun, Dr. Anita, and Dr. Sonia. Of course, the convener of today's webinar, again, I thank Dr. Sonia, coordinator Dr. Anita, very well. And of course, the Zoom platform for giving us the opportunity to for this webinar. And I thank all the delegates who have joined in. And of course, last but not least, I would like to wish all the best for to Dr. Sneha and Dr. Bharti for their forthcoming elections. Thank you, one and all, and good night, one and all.
Thank you, Dr. Suman. Dr. Vidya, excellent panel discussion. Sorry, I had to go in between to meet the Deputy Commissioner because there was a meeting in the DC office, so I had to leave in between. And now I am back. Thank you very much.
We would have loved to serve you a cocktail of insulin, ma'am, 30-70.
Yeah. Yes.
That's the take-home message for us with an evening cocktail of insulin 30-70, which we'll never forget.
Yeah, and there was a question, I think I don't know whether you people answered that why Dr. Arjun wants to know why 75-gram glucose is the schedule and not 100 milligrams.
Not seen there.